we'll be looking at acute kidney injury as our tutorial for this week. Acute kidney injury. All right, our learning objectives is we want to understand the causes and pathophysiology of acute kidney injury. We want to understand the different criteria for the diagnosis of acute kidney injury. We want to understand the indications of renal replacement therapy and the different modalities of achieving renal replacement therapy. Then we'll look at some publications about some of the medications used in management of acute kidney injury. Now, this is a cross-section of the kidney, just a reminder. You know that the kidneys are divided into the cortex and the medulla. In chronic kidney injury, one of the things you will see is loss of corticomedullary differentiation with a small kidney. On ultrasound, it shows a chronic kidney injury state. Now, this is just to remind us of what we know. This is a cross-section of the kidney, a very important organ that performs very important functions in the body. Reminder of the basic renal physiology. You remember the nephron. A nephron is the functional unit of the kidney, which is capable of forming urine. And it has two major components, the glomerulus and the tubules. This is a schematic diagram of what a nephron looks like. The tubules have proximal tubules, like you can see, the loop of Helen, the distal convoluted tubules, and the distal collecting tubules before you get to the collecting duct. So this is this functional, single functional unit of the kidney. So the whole of the kidney is made up of nephrons that are capable of urine formation. All right, so having looked at the background, we look at what is AKI. Acute kidney injury, also known as AKI, used to be known and represented as acute renal failure, and represents a spectrum of disease conditions that range from subclinical renal injury to complete renal failure. Studies have shown that acute kidney injury is very common in the ICU and leads to increased morbidity and mortality. In fact, presence of acute kidney injury in your critically ill patient increases mortality to more than 50%. Outside of the ICU, 7% of all hospitalized patients have clinical diagnosis of acute kidney injury, while 36 to 67% of all patients admitted into the ICU will have clinical features of acute kidney injury. Now, this is to underscore the importance of this disease entity, and it's also very important for us to understand the pathogenesis, the causes, and how to tackle it in the ICU. All right, so by way of definition, it is a rapidly developing, often reversible kidney injury. All right, it usually occurs over a few days, and there is a major cause of death during acute illness, especially in the intensive care unit. Suffice to know that it may develop with or without pre-existing renal impairment. So some patients who never had issues with their kidneys may come down with acute kidney injury when they fall ill, or when they suffer trauma, or they undergo major surgery, especially those surgeries involving the heart and great vessels. As we learned before, this has to do with a lot of, large fluid shift with hypovolemia, resulting in hypotension and hypoperfusion. All right, it's common, especially for patients undergoing surgery, in presence of liver impairment, hyperrenal syndrome cases, patients undergoing obstetric surgery, and any condition that can predispose the patient to hypotension. All right, so you can see that AKI covers a wide spectrum of disease entities and the patient age groups and patient varieties. Renal physiology, the kidney receives about 20% of the total cardiac output. And the blood supply is by these following arteries, like we can see. All right, and for the kidney to receive 20% of cardiac output, anything that affects cardiac output, systemic resistance, vascular resistance, we have a huge impact of renal perfusion. And this is one of the reasons, the predisposing factors for development of acute kidney injury. Sometimes we'll come across more often is what we know as the glomerular filtration rate. And it's actually an interplay between hydrostatic pressure and the oncotic pressure within the kidneys. Hydrostatic pressure is greater in the glomerulus, all right, than within the tubules, and the hydrostatic pressure forces filtrates out of the capillary bed into the tubules. Oncotic pressure, on the other hand, is generated by the non-filtered proteins and helps to retain fluid in the intravascular space. So the glomerular filtration rate, the rate at which filtrates are released from the glomerulus, therefore is equal to K constant, which is hydrostatic pressure minus oncotic pressure. Normally, it ranges between 100 ml per minute per 1.72 square meters. All right, so this is the normal glomerular filtration rate, or in normal patients. All right, so epidemiology in 2015 study revealed that among 279 ICU patients, that the incidence of AKI is about 32.9%, irrespective whether they are trauma or not trauma patients. And this increases ICU mortality by as much as tenfold. All right, so this study noted that the incidence of AKI in ICU was actually with the older age group, history of diabetic mellitus, higher length of stay in the unit, and those patients who are mechanical ventilation and vasopressor therapies are actually more prone to develop AKI in the ICU. Okay, I tried to mention this before, but let's just go over it. All right, some definition of terms. All right, AKI refers to a sudden decline in kidney function. And when we talk about kidney function, think about all the things that the kidneys are involved in. All right, causing fluid, electrolyte, and acid-base imbalance resulting from reduced glomerular filtration rate. So when we say patient is oliguric, what do we mean? It means that the patient is producing less than 400 ml per day. Or if we break it down, that means the urine production per hour is less than 17 ml. The common ones we are used to is when the patient has less than 0.5 ml per kg per hour for at least 2 hours. And this is important. We don't wait for 12 hours or 24 hours for us to say the patient is oliguric, right? Because at that time, a lot of harm might have happened. Uremia might have developed. So when a patient has less than 0.5 ml per kg per hour for at least 2 hours, we declare the patient oliguric. Anuria is when urine production is urine output is less than 50 to 100 ml a day. Now keep this in mind, and this underscores the reason why urine output should be measured hourly. All right, this is important. I see in a number of our units that we wait till the end of the shift to calculate urine output. A lot of times we mix some subclinical AKI that could have been managed earlier had we been doing and charting urine output every hour. So don't wait until 12 hours at the end of the shift for the nurses to calculate for you, insist on the hourly charting of your urine output so that you can pick AKI early. The earlier AKI is picked, the better the prognosis and outcome. Like I mentioned to you before, this is a graph of the relationship between GFR and serum creatinine. Note that sometimes the reason why GFR may not be a very suitable marker for AKI is that you can see that for a range of between 50 to 120 ml per minute, all right, there's no change, all right, when GFR reduces from 120. Remember, we said 100 per ml per minute is the normal GFR, all right? All right, please mute your mic when you're joining. It causes a lot of distractions. So when GFR even goes down from 120 to as low as 150, there's little or no change in serum creatinine. So you can imagine that there's reduction in urine function and in kidney function, all right? But serum creatinine begins to rise only after the GFR has reduced to about 50. And so you can see that glomerular filtration rate is a poor marker for kidney function. All right, a reduction of GFR is not reflecting a change in serum creatinine. This is what, and that's why in most places we don't use GFR as a marker of kidney function. I hope we understand that clearly. Now, so there are different criteria that have been developed or proposed to make a diagnosis of acute kidney injury. Some of the common ones are the rifle criteria. And this was proposed way back in 2002 by the Acute Dialysis Quality Initiative. All right. We can see from the table, rifle criteria, R means risk, kidney at risk. I is when there's kidney injury. F when there's kidney failure. L is when there is a loss of kidney function. And E is end-stage renal disease. And you can see that there's no glomerular filtration rate here, it's more creatinine clearance and urine output. So the two parameters that are used in rifle criteria are the creatinine clearance and the urine output. All right, so when the kidneys are at risk of normal creatinine level increases by 1.5, and urine output is less than 0.5 ml per kg per hour for 6 hours. When creatinine clearance creatinine level is like twice the normal value, and urine output is less than 0.5 ml per kg per hour for 12 hours. This is more of duration, all right? There's acute kidney injury. This is when actually we should start instituting management. And then when creatinine, the increase in serum creatinine is almost about 3 times normal, which is more than 4 milligrams per DL. All right, urine output is now less than 0.3 ml per kg per hour for 24 hours, where you have established failure. However, we talk about renal loss, renal function loss, when all of this happens in more than 4 weeks going, and this shouldn't, our patients in ICU shouldn't be allowed to get to this stage. Then end stage renal disease is when the patient now has chronic renal disease or the patient passes on. All right, the second criterion that is used in the AKI is the Atkins criterion, all right, which is acute kidney injury network. This was come about from an international multidisciplinary organization that involve nephrologists. This criterion defines AKI as an abrupt reduction in kidney function, which is defined as an absolute increase in serum creatinine of more than 0.3 milligram per DL. Now, we need to put this in our brain. When there's an absolute increase in serum creatinine more than or equal to 0.3 milligram per DL, or as high as 26.4 micromole per liter, or a reduction of urine output of less than 0.5 ml per kg per hour for more than 6 hours. So acute kidney injury has developed with these parameters. All right, when we compare the RIFO criterion and the Akin criterion, you find out that in the original RIFO criterion, GFR values were listed as reference. But like we saw from the graph earlier on, we realized that they do not precisely agree with the changes in serum creatinine and were subsequently removed. All right, for the Akin network, the change in serum creatinine from baseline follows RIFO criterion with an additional option to use 0.3 milligram per day increase if this is observed to occur within a 48-hour period. Now, the most recent one that we use in our ICUs here is the KIDGO staging, the KIDGO criterion. KIDGO means kidney disease improving global outcome. All right, and this was published in the Clinical Practice Guideline for Acute Kidney Injury International Supplementary Edition. All right, in 2012. In most places, you won't hear RIFO criterion anymore. You will hear KIDGO staging. And this is what we use right now. So the KIDGO staging stages acute kidney injury into 3 stages: stage 1, stage 2, stage 3. Stage 1 and is simpler because it just makes use of the serum creatinine levels only. All right. So stage 1 is when there's an increase in serum creatinine level by more than 0.3 milligram per DL within 48 hours. Or there's an increase in serum creatinine of between 1.5 to 1.9 above the baseline. That's stage 1. Stage 2 is when you have an increase in serum creatinine of between 2 to 2.9 above the baseline. Stage 3, which corresponds to end-stage renal disease, is when you have an increase in serum creatinine that is above 3, the baseline. All right, or you have an absolute value of serum creatinine more than 4 milligram per DL. Or, this is important, and when there are clinical indications for initiation of renal replacement therapy. The KIDGO criteria has been adopted globally and is the commonest criterion that is used in most ICUs as we speak. One of the reasons is because it's simpler and it takes into account the serum creatinine levels, all right, which can be absolute or you compare with baseline. So if you are working with me and you say, Prof, I think this patient may have AKI, I want to ask you what KIDGO stage are we? And now that gives us a clear picture of what we're talking about. It's a common language that we'll use. All right, when we come to the etiology of acute kidney injury, all right, I just took this diagram to give us an example, all right, a picture of what we're talking about. So causes, we can have pre-renal, renal, and post-renal causes. All right, pre-renal causes most of the time is due to hypoperfusion from hypovolemia or hypotension. All right, renal causes could be due to vascular disorders, glomerulonephritis, interstitial nephritis, or tubular necrosis. And tubular necrosis can actually be from ischemic injuries, toxins, or pigment. Post-renal causes most of the times are obstructive in nature. And it's very important. The post-renal cause is very important because before you can declare a patient to be in renal failure or kidney injury, you must rule out post-renal causes. You must rule out obstruction because patients have had obstruction to urine flow with very distended bladder, and people have began to treat that patient for acute kidney injury without relieving the obstructions. And once the obstruction is released, they just see large volumes of urine, especially in sedated mechanically ventilated patient, where the patient cannot communicate level of pain, and the patient is not examined on a daily basis. And this is another reason why we should always examine our patient head to toe, even in the ICU, because there are some things you may pick that you may overlook if you don't expose your patient. All right, you're used to me now, you will know that I like lemoning. So if you're asked what are the risk factors for developing AKI in the ICU, risk factors, just write chronic D. Chronic D will give you an overview of the risk factors for acute kidney injury. Number one, when there's a presence of chronic kidney disease, all right, that patient is at risk of developing acute kidney injury when admitted to the ICU. Patient in heart failure, hypovolemia or hepatic failure, all right, when there's history of renal impairment in the past, when the patient had previous history of oliguria as defined as 0.5 ml per kg per hour, or patient has history of obstructive uropathy, when the patient has neurological impairment, which renders the patient not able to have access to fluid intake, all right, the patient becomes fluid depleted, hypovolemic, and predispose the patients to develop AKI. In the presence of infection/sepsis, all right, patients who have contrast CTs, contrast iodine-based media within the past week, if we have time, we'll look at contrast-induced AKI and how you can prevent it. All right, because patients, a lot of our patients in ICU often undergo contrast CT for diagnosis and procrastination purposes. So patients that undergo contrast-induced investigations or contrast-based investigations, CT and all that, are at risk of developing AKI. Drugs, yeah, we're going to look at it as we go on. Some of the drugs that are nephrotoxic, patients on medication are nephrotoxic at increased risk of developing AKI. And patients who are diabetic, age above 65 years, these are risk factors for developing AKI. And the reason why we need to know about these risk factors is that we can prevent the establishment of AKI if we can take into account some of these risk factors. All right, so etiology, we did say that it could be pre-renal, all right? And it's also known as functional AKI. Pre-renal AKI is also known as functional AKI, which results from hypoperfusion, all right? Responsible for 30 to 40 cases of AKI. The good thing is that it resolves when you treat the underlying disorders. For instance, if it's bleeding or hypovolemic, or patient who is behind fluid and with fluid resuscitate the patient, most of the times the AKI also improves. And AKI can be secondary to hypovolemia, decompensated or acute decompensated heart failure, drugs that impair renal autoregulation, and all that. These are some of the causes of pre-renal. Renal is also known as structural or intrinsic AKI. Renal AKI is also known as structural or intrinsic AKI. And the primary pathology is that there is intrinsic kidney damage is responsible for 50% of cases of AKI. It could actually be due to acute tubular necrosis, in which case there's injury to renal epithelial cells, could result from severe sepsis, shock, drugs, antibiotics, contrast dyes, like I mentioned, and all the homoglobinuria, for instance, from massive muscle loss or massive, tissue injuries and all that. All right, with high production of myoglobulin in the urine. It could actually also be due to acute interstitial nephritis or acute cortical necrosis. And this actually occurs more in obstetric patients present with placenta abruptio, pre-eclampsia, and those who undergo illegal or septic abortion. Post-renal is also known as obstructive, and this is post-renal. All right, it's responsible for 10% of cases, and it can result from papillary necrosis, ureteric obstructions, or you can actually get it from extra intraluminal masses. All right, know that renal stones rarely will cause it, except if you have only one kidney, if that patient has one kidney. So in the ICU, the common causes of acute kidney injury in the ICU include what I call the 4X, the most common ones, 4X. Sepsis is actually the commonest cause of acute kidney injury in the ICU. And the teaching is that the kidneys are the first organs to fail in multi-organ dysfunction. And actually, they are very forgiving. They are the first organ also to recover. Now, if you have a patient with severe sepsis with acute kidney injury, and you're able to reverse that acute kidney injury, there are higher chances that your patient will survive. So they are the first organs to go and the first to come back with aggressive management. Major surgeries like heart and major vessel surgery, shock state, look at Apple state, acute decompensated cardiac heart failure, case of hypovolemia, and substances like medications. These are the 4 A's. Other causes are hyporenal syndrome in case of liver failure, trauma, cardiopulmonary bypass, when you have abdominal compartment syndrome and abdominalitis. Now, studies have been ongoing to look at new biomarkers for AKI that may aid in prompt detection and monitoring of progress of AKI. And two commonest ones, as at the time I prepared this lecture, the two commonest ones are the NGA, the neutrophil gelatinized associated lipocalin. All right, and it's been said that it mirrors renal tubular stress or injury. All right, you could assay for the serum or urine concentration, and both urine and serum concentration of this substance is both diagnostic and prognostic. Cystatin C also closely correlates with glomerular filtration rate, and it is more important than serum creatinine measurement, especially in chronic kidney disease. As at the time of preparation of this lecture, its clear role in diagnosis and prognostication of AKI has not been fully defined, but it's very important, especially in chronic kidney disease states. Now, how does acute kidney or acute renal failure develops? All right, glomerular dysfunction. It starts with glomerular dysfunction. All right, don't forget that the normal function of the glomerulus is filtration. All right, so when there's a destruction or dysfunction of the glomerulus, this will lead to a fall in glomerular filtration rate. And what does this mean? It leads to retention of substances which are normally cleared by filtration. So we could have tubular dysfunction. Don't forget that the normal function of the tubules is reabsorption. So this leads to voiding of large volume of dilute urine, which should normally be reabsorbed, and you have what we known as polyuria. And we faces acute kidney injury, one of the phases polyuria, and this tells us about tubular dysfunction. Then we can have increased sodium chloride delivered to the macula densa. And don't forget the macula densa plays a role in renal-mediated blood pressure regulation. And what this happens is that when you have increased salt deposition at the macula densa, it leads to destruction of the tubular cells with destruction of this feedback mechanism. Obstruction of tubular lumen from necrosis of tubular cells, which leads to increase in tubular pressure and reduction in GFR. Don't forget that GFR is hydrostatic pressure minus oncotic pressure. All right, so when there's increased tubular pressure, the hydrostatic pressure also, the glomerular filtration rate will drop because the effective pressure that leads to filtration reduces at the end of the day. So what are the clinical features of acute kidney injury or acute renal failure? We have azotemia, we have reduced urine production, can lead to acidosis, metabolic acidosis, electrolyte imbalance with hyperkalemia, hypermagnesemia, hypophosphatemia, phosphatemia leading the pack. You can have hypervolemia with fluid retention, and hypertension may also develop as a consequences. So how do you what are the investigations that will help you to make a diagnosis? As you're taught in medical school, history is very important in trying to make a diagnosis of any disease condition. Physical examination, like I told you, always expose your patient in the ICU to do a head-to-toe examination. You may pick some things that will help you in making a diagnosis. For instance, if you palpate the abdomen, you will see that sometimes in obstructive uropathy, the bladder may be very extended, distended. It may just be due to the fact that urethral catheter is obstructed or is kinked, and just that physical examination will save you and your patient a lot of headaches. You want to obtain your laboratory investigations, your ENU and creatinine and your blood urea and nitrogen levels. You want to do your kidney urea bladder radiography. Sometimes you want to do a renal biopsy. And one of the very important components in the SC is your bedside ultrasound, which will actually help you differentiate between an acute and renal disease. Like I mentioned before, in chronic state, you will see lack of corticomedullary differentiation. The whole kidney look like one, and they are small in sizes. CT scan, contrast or no contrast, you need to be sure what you want. And if you are doing a contrast CT, maybe of the abdomen or the chest or wherever it is you want to do, you need to institute some measures to prevent contrast-induced AKI. And you can also do retrograde pyelogram and whatever it is. But my take is that do not order for investigations that are not helpful in making a diagnosis. All right, there are 4 phases of acute kidney injury. All right, and this chart actually was adopted from previous publications for which due acknowledgement has been given in the reference session. So we have 4 phases. We have the onset phase. All right, the onset phase lasts between hours to days. All right, here the significant common triggering events are significant blood loss, bones, fluid loss, diabetes insipidus. All right, renal blood flow, all right, is 25% of normal in this period. And tissue oxygenation is also about 1/4, and urine output at this stage is less than 0.5 kg per hour. All right, this is the onset stage of acute kidney injury. Then you have what is known as the oligouric phase, all right, or the anaerobic phase. Here, this occurs between 8 to 14 days or longer, and depends on the nature of AKI and whether you have instituted renal replacement therapy. At this stage, urinary output may be as low as 100 ml per day. All right, there are usually increases in your BUN and creatinine levels. At this stage, you have electrolyte disturbances, acidosis, and fluid overload. Diuretic phase is when the kidney begins to show some signs of recovery, and it also occurs between the 1 week and 2 weeks. It occurs when the cause of AKI is being corrected. Maybe it's hypovolemia. Renal tubule scarring occurs and edema. There's increased glomerular filtration rate. Daily urinary output now goes above 400 mils per day. And there are possibility of electrolyte depletion from excretion of more water and osmotic effects of high blood urea nitrogen. The recovery phase begins to resolve. There's normalization of fluid and electrolyte balance. And your glomerular filtration rate begins to return to 70 to 80% of normal. Actually, this takes place between several months to a year. So these are the phases of acute care, AKI. All right, I did mention the contrast-induced AKI, and the incidence is actually less than 1% patients who have normal renal function. It increases significantly in patients who have existing renal insufficiency. All right, the risk factors for development of contrast-induced AKI includes presence of renal insufficiency, diabetes, patients with multiple myeloma, and also the contrast, the osmolality of the contrast medium used, and the volume. The higher the volume, the more the patient is predisposed to contrast-induced AKI. The clinical features actually include an onset times of 24 to 48 hours. When your patient begins to show signs of AKI, between 24 to 48 hours of exposure to a contrast medium, maybe for CT or whatever, and it lasts between 5 to 7 days. Most of the time, there's no reduced renal failure, and dialysis is really needed. But the important thing is that before you send your patient for a contrast investigation, contrast medium investigation, or patient that will have contrast dye injected into them, you need to, number one, ensure that do we need contrast in this patient? There are investigations that you can do in no contrast. So you want to ask yourself and convince yourself that this patient, you weigh the risk-benefit ratio to assure yourself that this patient indeed will require a contrast study. So once you have made up your mind, this patient requires a contrast study, you want to give the patient adequate hydration, and you tell your radiologist or your radiographer, please, let's keep the volume of the contrast to minimal level as much as possible. And you have a choice to choose which contrast to use. You rather use the low osmolar contrast medium. So prevention, they say, is better than cure. It goes well in every life facet. All right. So the first thing in management of AKI is to prevent it. How do you prevent it? You want to recognize at risk of AKI. Therefore, post-operative state, cardiac surgery, septic shock. You want to do adequate fluid resuscitation and maintain blood pressure, adequate blood pressure with inotrope if needed. All right. You want to prevent progression from pre-renal to renal. You want to arrest the AKI at the pre-renal state. By all means, preserve renal perfusion by ensuring isovolemia, ensuring that you have adequate cardiac output and normal blood pressure. MAP normally with target MAP between 65 to 75 millimeters of mercury. And you want to avoid the nephrotoxic agents, your aminoglycosides, your NSAIDs, and all that. We'll see the list of medications that should be avoided in patients who are at risk of AKI. Now, I brought this in just to let us know that your NSAIDs are not as innocent as we think more of time, because they have been implicated in multiple causes of renal impairment. So their use should be restricted in patients at risk. All right. And they can cause both pre-renal, renal, and post-renal. Acute kidney injury. They can cause the different types of acute kidney injury, pre-renal, renal, and post-renal. In pre-renal, the pathogenesis is that they block prostaglandin-mediated vasodilatation or the afferent arteries, and this limits the ability of the kidney to regulate its own local blood flow. Or NSAIDs have been implicated to cause acute interstitial nephritis, which is a cause of renal AKI. Long-term use of NSAID can cause renal papillary necrosis, all right, leading to sloughing of medullary papilla, and this causes obstruction to urine flow. So you can see your NSAIDs can actually affect your kidneys at the different stages of development of AKI. All right, so management of AKI, systematic approach is always advocated. All right, initial resuscitation, I mentioned this before. Optimize your hemodynamics and oxygenation. You want to rule out urinary retention, all right, from causing oliguria. So you want to do suprapubic percussion of full bladder. You want to check your urinary catheter, and at all times do your bedside ultrasound of the kidneys. All right. Okay, somebody's already thanking me when I'm not done. Thank you. Okay, you want to confirm the cause of oliguria? Is it pre-renal, renal, or post-renal? And this you can do via history taking. Is there any history of fluid loss? All right, is there been vomiting and diarrhea? Is there been hemorrhage? Or is there been limited access to fluid? All right, you want to examine for evidence of hypovolemia. And investigations, specific investigations in AKI management is urinary sodium, which can actually differentiate between pre-renal and renal. When urinary sodium is less than 20 milliequivalent per liter, it shows that it's pre-renal. And when it's more than 40 milliequivalent per liter, this shows a structural or intrinsic renal cause. So urinary sodium can be very, very important. All right. Okay. All right. So fractional extraction of sodium is less than 1% in pre-renal and more than 2% in intrinsic renal. Urine osmolality also will differentiate between renal and pre-renal. If it's more than 450 milliosmol per kg, it shows a pre-renal picture. If it's lower, between 280 to 300, it shows a structural renal cause. You also want to do your blood urea nitrogen creatinine ratio. The number is actually 10:1, but if you have BUN creatinine ratio more than 20, is a pre-renal cause. All right, creatinine kinase, when it's less than 25% of normal, all right, it shows an acute oliguric phase. Renal ultrasound will help you to rule out post-renal causes. Monitoring, you want to, like I mentioned, the emphasis on hourly urine monitoring cannot be oversaid. All right, so you want to monitor your urine output every hour. All right, not wait till the end of the nurse's shift. I hope I've emphasized that enough. You want to do your continuous hemodynamic parameters. There's always an indication for invasive arterial blood pressure monitoring. I tell my medical officers and residents working with me, even if you are not transducing the blood pressure, do an A line all the time. All right, but in cases of AKI, you want to transduce because you want to see bit by bit reading of your. But if you are not transducing in other cases, continuous sampling of your arterial blood for ABG is an indication for setting an A line. So every patient that comes into our unit must have a central line and A line set up. I don't know what the practice is in most of our centers, but this is close to ideal. Now, to rule out abdominal compartment syndrome, you want to do a continuous intra-abdominal pressure monitoring. All right. Normal should actually be less than 12 millimeters of mercury. And when you have intra-abdominal pressure greater than 20 millimeters of mercury, you have abdominal compartment syndrome, which needs to be relieved as soon as possible if your renal function will improve. All right, I copied this from one of my references, and I think it's very good here. All right, so, in treating AKI, you want to do the ABCD checklist. You want to address drugs. The drugs are on the right side. What drugs are this patient on? Is any of those drugs the patient on nephrotoxic? And you want to discontinue such drugs. Your AC inhibitors, your NSAIDs, your ARBs and tacrolimus, all right, the alter GFR, your aminoglycoside and amphotericin B and cisplatin will cause tubular toxicity. Your NSAID and rifampicin for your TB patients will cause interstitial nephritis. Your antiviral acyclovir and your common ampicillin will cause crystal nephropathy. So you want to check a list. What I do a lot of time is I always want to look at the drugs or medications these patients in the ICUs are on to ensure that I don't continue to give a patient a medication he does no longer require and therefore not cause harm. Don't forget that our profession demands that will cause no harm. So your B, you want to boost blood pressure as much as possible with fluid and anotropes and vasopressor as the need may be. You want to do your urine test all the time. Like I said, urinary sodium, all of you, and you want to exclude obstruction. So if you have a case of AKI, you want to go through the ABCD checklist. I hope this will be useful. All right, so if you have a case of hypovolemia, you want to correct fluid deficit, you want to do a fluid bolus with 20 to 30 ml per kg. All right, and you can do a fluid challenge to 1 liter of crystalloids or 500 ml of colloids over 30 minutes. There have been issues with low dose dopamine. I remember earlier on that dopamine was a darling in the critical care settings, but unfortunately that's falling into disuse because it's been found that it does not really provide any additional benefit. Low dose dopamine those days was projected as giving us good renal perfusion, but several studies have discredited its use. Dobutamine to augment your cardiac output, yes. And furosemide, I'm going to show you some slides that talk about the potential benefits and potential pitfalls of the use of furosemide. And there have been issues whether you do bolus and continuous infusion. I'm a firm believer of continuous furosemide infusion because it's been found to give a better diuresis than your bolus doses. AKI, you want to correct metabolic problems, all right, and such as hypo and hyperkalemia. Don't mind this handwriting. I think I overrode this. Hypo and hyponatremia, hyper and hyponatremia, hypercalcemia. You want to do your daily blood works to ensure that you're on track. All right. So you want to also look and correct specific conditions for patients who have developed inflammatory renal injury due to sepsis or due to shock. You want to do supportive care with your antibiotics, non-nephrotoxic antibiotics. And for contrast-induced renal failure, prevention is the key. You want to adequately hydrate the patient by volume loading them by 100 to 15 ml per hour before the procedure. And you want to give the IR acetylcysteine 600 milligram BD 24 hours before and after the contrast studies. For patients whose acute kidney injury is due to acute interstitial nephritis, you want to discontinue offending medications like your NSAID, like I mentioned, and steroid use as helps. In myoglobinuriria, you want to correct your hypovolemia, and sodium bicarbonate may help in such instances. All right, I doubt it if we'll be able to go through renal replacement therapy because the time is more than an hour, and I don't want this to go beyond 1 hour. I think we can reschedule renal replacement therapy till next week because we've got plenty about under it. You can see there's no way we can finish it in the next 10 minutes because I don't want to rush it. So I think we'll stop here today on the acute kidney injury. Next week, hopefully, God willing, we'll continue with renal replacement therapy. At this junction, I'd like to welcome questions, contributions, addition, multiplication, subtraction. So the floor is open if you've got any questions. I'm going to stop recording now.